My name is David Kalmus. I'm a professor of radiology at the Mayo Clinic in Rochester, Minnesota. Vertebroplasty is a minimally invasive way to help the pain related to typically osteoporotic vertebral compression fractures. It's done typically in a radiology suite, sometimes in an OR, and a biopsy needle is put through the skin into the bone after local anesthesia, and then a slurry of cement and barium, so we can see it under X-ray, is simply injected into the bone. The needle is removed and the patient recovers. It's hard to get exact numbers. You can look at Medicare data or talk to industry. Industry tells me that the number of vertebroplasties done last year was on the order of 75,000. A sister procedure called balloon assist vertebroplasty or kyphoplasty was done in about 100,000 patients. We have a paper being published in the New England Journal of Medicine entitled A Randomized Trial of Percutaneous Vertebroplasty. In that trial, we attempted to isolate the impact of the cement on the apparent pain relief from the procedure. So patients with painful osteoporotic compression fractures were randomized either to get a full vertebroplasty or to what we called a control intervention. In the control intervention, we simulated the vertebroplasty but did not infuse any cement. The control patients, like the treatment patients, were brought to an angiography suite. They were given sedation by vein, their backs were cleaned off, and local anesthesia was given under the skin and over the bone. And then we simulated the procedure. Following this, patients were recovered as normally. The patients remained blinded to their treatment type, as did the people doing the telephone follow-up throughout the study. The primary outcome was at 1 month. Looking at a number of outcomes, the primary outcomes were both pain and dysfunction. Dysfunction was measured using the modified 23-point Roland Morris Disability Questionnaire. Those questions are very simple yes-no questions, such as, can you walk upstairs without holding a handrail, or is it impossible because of your back pain? There were multiple secondary outcomes, including quality of life questions, as well as fractions of patients requiring narcotic analgesics. Patients were allowed, after 1 month, to cross over both from the control procedure to the full vertebroplasty, but they remained blinded to their treatment type even if they crossed over. Patients were followed for a total of 1 year, at which time we did a follow-up radiograph in order to determine whether the patient had suffered a new fracture in the interim. The trial was originally designed to enroll 250 patients. It was funded by the NIH. We had fairly substantial challenges in patient enrollment early in the study. In order to overcome that challenge, we were given permission to enroll patients from outside the U.S., primarily Australia and the United Kingdom. After those outside U.S. sites were enrolled, we did fairly well with enrollment and ended up with 131 patients. The 68 patients randomized to vertebroplasty achieved substantial benefit immediately after the procedure, pain going from 7 to about 4. Surprisingly, though, the 63 patients randomized to the control procedure, and again blinded to the treatment type, achieved almost identical degrees of pain relief that was immediate and sustained to a month. So at 1 month, the groups were essentially identical in terms of pain severity. They were essentially identical in terms of improvement in function. We did find one parameter where there was a trend toward improvement in the vertebroplasty arm. That is to say, 2/3 of patients randomized to vertebroplasty achieved what we call the minimally clinically relevant improvement in pain, a 30% improvement, as compared to 1/2 of patients in the control arm. That approached statistical significance but did not reach it. But multiple other secondary outcomes, including quality of life measures, were identical between groups. So, based on our primary outcome, we would cast significant doubt on the efficacy of the cement in achieving the remarkable pain relief in both groups. We did have a substantially higher fraction of patients electing to cross over from the control group to the vertebroplasty group, but we don't know whether that was an effective bias, a treatment effect that we missed, or other unknown factors. Crossover is a difficult issue in a device trial. In a drug trial, when the drug can be washed out, it's less of an issue. In a permanently implanted device trial, crossover is difficult because once the implant is in, it's not coming out. The crossover in our trial was not an outcome. In fact, The sister publication in the New England Journal from Dr. Bookbinder did not allow crossover, and in that way is a more pure trial in terms of long-term outcome. Our trial is a 1-month trial. Even though we followed patients for a year, after 1 month, the crossover really complicates the statistical analysis. The crossover was done simply to enhance patient enrollment. We felt that IRBs, ethics committees, would have a lot of problem in having a no crossover trial like they did in Australia. In addition, our referring physicians and, frankly, my colleagues here at Mayo and elsewhere were very concerned about withholding indefinitely an apparently efficacious treatment. So the crossover was a way to enhance patient enrollment. It was not an outcome. The issues of which patients we enrolled is a central aspect to the importance of this study. It's only applicable to the types of patients we enrolled. We endeavored to enroll the typical patient. In the US, at least, we don't offer vertebroplasty immediately after the fracture because 8 in 10 patients after a month will achieve complete or near complete pain resolution without augmentation. Now, patients may be suffering in the meantime, but still, we typically do not offer vertebroplasty in the acute setting. Now, is it possible that patients with acute fractures might benefit substantially from an early vertebroplasty? That remains possible, and that is not something we studied in our trial. However, I would caution people considering a trial like that, they really are competing with Mother Nature. And if Mother Nature allows rapid healing of the fracture, it's hard to show a benefit. We thought our study design was more likely to show a benefit because we specifically selected patients who were not healing on their own, and therefore thought vertebroplasty would be efficacious. That being said, there may be other important subgroups, not limited to duration of fracture, but factors such as type of fracture, severity of fracture, imaging findings in MRI, that might portend a better outcome after vertebroplasty. Unfortunately, the size of our trial, probably even after combination with Dr. Bookbinder's trial, will not allow us to identify those subgroups with confidence. That is the purview of future research.